Fantastic. Thank you so much. Thank you so much for the invitation. I am so excited to be here and to be a part of this project with you all. I'm going to share my screen. 1 second. Let's see. I am on my partner's computer, which is very exciting because we have very different setups. And so I'm looking for my screen. Let's see. Well, while I am looking for that, I will tell you a little bit about myself. How do I get to mine? Sorry, friends, 1 sec. That one, and then what? Hit share, and then will it let me do this? Oh, okay, great. Love it. Thanks, babe. Okay, that was my partner, Becky. So what I'll do first is just quickly introduce myself because I think it's always important to know kind of who you're hearing from, but more important to know why this is relevant. So I will start with just my contact information here at the bottom, and then I have it later in the presentation as well, and then I will send you the presentation so that you have all of that. These are my disclosures. So I have no financial disclosures, although I find it important to disclose that I am a national board member of OutCare Health, which I will talk a little bit more about in a bit. But OutCare Health is an organization that was started by a resident in Indiana and was developed so that people in the LGBTQ community could identify providers of any kind of healthcare that would be safe for them to visit. So that means people that are physicians, people that are nurses, people that are physical therapists, and whatever else would join this list. The providers join the list, and then patients and the general public can access this list for free and find people who have self-identified as safe and trained. So I will talk a little bit more about OutCare Health toward the end as far as resources for you, but I think it's important that I disclose that. I also think it's important that you know who you're hearing from. So I'm an OBGYN. I am also a white woman. I'm cisgender. I identify as queer. I'm a mom. I'm an MD, and that plays into a lot of things. I provide abortion care. I have lived most of my life in the Midwest. And I am sorry to say that I'm a dog person. And I want you to know that I am open and tolerant of cat people. I lived with a cat person for a long time. I even lived with cats for a long time. But I am who I am, and it's important to recognize that about ourselves. So as I am talking, these are my biases, and I invite you to query your own biases and see how you approach information, and especially topics that may push the boundary of where you are comfortable. So trauma-informed care is something that can be difficult to wrap your head around. So this is the general outline for what to expect for our time together today. We're going to talk about what counts as trauma and what an ACE is, as well as what is specific about trauma for the queer population. And I'm going to say right now that I will, instead of using all of the letters of the alphabet, the LGBTQAI+, I will just talk about the community as the queer population. It's a little bit of shorthand. It is not all inclusive, but I wanted to say that up front so that you understand what I mean when I say the queer community or the queer population. And then we'll talk about what trauma-informed care is and how it is different than a standard practice. We'll talk about what that means in your practice and what kind of changes you can make. I have lots of resources, both for you and for your patients. And then I have a bunch of references for you as well. So as far as trauma and what the ACEs are, I first want to just tell you that this is very personal for me. So this is not a topic that I learned about as a resident or learned about as a medical student. It's not something that I learned about in medicine per se. It's something that I learned about as being a queer person and learning about the traumas of my friends, of my family members, of my people. I was in a heterosexual passing relationship for a long time. And so I flew under the radar as a queer person for many, many years. And as such, escaped some of that trauma that many of my friends and colleagues experienced and continue to experience. And then when I sort of came out unintentionally, didn't think I was in the closet, but I sort of was by accident. When my situation shifted and it became more obvious, my identity, I started noticing and experiencing more of those traumas, whether they were micro traumas or just the big old kind of traumas. And it made me understand the things that my friends and colleagues have lived through much more obviously than I have. So it became a sort of passion project for me in that this is a very personal thing. This is a picture of me and my partner, who is not only my partner, but also my tech support since she just came and rescued me. This is Becky, and I will refer to her a little bit throughout the presentation, but this is very evidence-based, even though this is like a topic that is so close to my heart. So trauma is identified or defined as an individual event or series of events or circumstances that is experienced by an individual and it has harmful or adverse effects. Those effects can be the individual functioning, the mental, physical, social, emotional, spiritual well-being of any capacity. So you'll notice that in this definition, it does not define what the event or circumstance is. So trauma does not have to be going to war and witnessing the atrocities of war. It does not have to be having like having a car accident. It does not have to be a giant earth-shattering, life-changing event. It can be a series of events or long-term exposure to events. Trauma is much more common and insidious than we previously understood. And that is most evident in the ACEs. So that's on the other side of the screen. The ACEs are adverse childhood experiences. This was developed in the sort of early 2010s by a group out of Philadelphia. And this really was groundbreaking. And I have the paper and some of the subsequent studies listed in the references for you to look at later. But I encourage you to look at this as far as what the three types of ACEs are and what of these traumas you have experienced. So most of the time when we think about trauma, we think about the first category, abuse. So it's physical abuse, emotional abuse, sexual abuse. Even emotional abuse is really hard to quantify, which makes it hard to measure, which makes it hard to believe from many of our scientific perspectives. Neglect is also abuse, whether that is a physical neglect or emotional neglect. But then look at these other things: mental illness within the household, abuse toward your parent, substance abuse within a household, an incarcerated relative, or divorce. All of these are traumas that, when they occur in childhood, add up to be physically relevant for our long-term health outcomes. I'll talk more about the ACEs here in just a moment. I should have said this right at the beginning, but I would welcome your questions throughout this presentation. Please do not feel like you have to stand on protocol and wait till the end. Just jump in. I can't see the chat, so if anyone puts anything in the chat, I'll just ask that somebody flag it for me. But please ask questions. So I would encourage you to think about your experience, think about the experiences of the people in your life and how these adverse childhood experiences may have impacted them or affected them. People with ACEs and what the data shows is that over a number of 6 ACEs. So if you look at this and you have, if you assign 1 point to each, if you have 6 of those, you have these health outcomes. So this is literally health changes based on your traumas as a child. So you're more likely to smoke. You're more likely to have contracted sexually transmitted infections by multiple times. And of course, this is controlling for other factors. You're significantly more likely to have chronic lung disease like COPD. You're much more likely to consider yourself an alcoholic by 7 times, 10 times more likely to have injected street drugs, and 12 times as likely to have attempted suicide. So the reason I bring up the ACEs is because they are almost ubiquitous. Everyone either has an ACE on them, on their own heart and in their own lives, or has many friends and loved ones who have ACEs within their health history. And that is exactly what it is. Our experiences are nothing less than our health history, and they contribute to our health outcomes. That is what this research shows us and was the basis for going forward. So we'll talk about a little bit more of that. What about queer community specific trauma? So before I move on, well, I just did, but before I move on, I'll ask you to just think for a moment about what you think this might be. So some of you might be queer, some of you might be within this umbrella term of this queer community. Some of you might not be and may have never really given it a lot of thought. That is all fine. Regardless of where you fall on these spectrums, I encourage you to think about what traumas you think as a population of patients the queer community has experienced. And the ones that I will bring up are legal battles first. So we fight continually, we continue to fight for marriage equality. We got the right and the ability to marry with Obergefell, the Supreme Court decision, and it is actively being challenged. So my partner, Becky, and I are scheduled to get married later this year. It's very exciting. And one of the reasons that we decided to get married now instead of waiting longer or deciding not to marry is that we may not always have that ability to get married. And we decided that that was the right thing for us. And we wanted to do it while we could and while it was legal. We want to be able to show up for each other in the hospital and in legal settings and for the kids and all of those situations. We want the same rights as people who marry those of the opposite sex. That is traumatic to think about. Military
Congratulations.
service. Hey, thanks so much. We're really excited. Military service is a huge contributor to trauma within the queer community, as you might imagine, both trying to serve in the military and what happens once you get into the military. The policy of don't ask, don't tell was supposed to be, was heralded as the answer, was heralded as the fix to the oppression of the LGBTQ plus community because of its permissiveness. But what it actually does is shut down people's identity. So that gets overturned, and then people are outed, people are still abused. Abuse is so rampant within the military anyway. And then on top of that, abuse within the queer community is even more. So that is all very complicated, very traumatic for a community of people who is trying to serve their country. I probably don't need to say a lot about bathroom access, but you could imagine that as people are encouraged societally to be themselves and to live their best life and to, own their identity and be comfortable in their own skin, then they are not able to use a bathroom in which they feel safe, in which they are protected, in which they feel like they fit in with the other people within that space. It is astounding to me when I go into places, especially doctors' offices and places like doctors' offices, and there are still gendered signs because it is really oppressive and deeply problematic to force people to identify their gender or to take their life into their hands by choosing which bathroom to use. And then there's conversion therapy. So I call Indiana home. I work in several other states, but I live in Indiana. And in Indiana, conversion therapy is still legal. And conversion therapy was actually recommended by our past governor, Mike Pence. Sorry to the country about Mike Pence. So I would encourage you to think about what laws live on your books still and what impact that has. So this person is holding a sign that says, "You can't cure us because we're not sick." What I always feel when I think about conversion therapy is just such incredible heartbreak, and when you think about how people are forced into trying to be something other than themselves. And that leads us to the next topic, which is the health outcomes. As you might imagine, they're real bad. They're real bad. People who are within the queer community are profoundly more likely to be victims of some sort of violence, whether that is rape, physical violence, stalking. I will especially draw your attention here to bisexual women right here. Their heterosexual counterparts have a rate of 35%. That is horrible to say that out loud. It is awful that our rates are 35%. Bisexual women have a rate of 61%. 61% of bisexual women have experienced rape, physical violence, or stalking by an intimate partner. These numbers reflect the experience that queer people have all the time, where we are targeted, where we are sort of rooted out and attacked. I live in a city where I feel safe. I have a giant, big old pride flag out front of my house and a bunch of yard signs. I'm not a particularly quiet person when it comes to my opinions, but it does not come without a level of disquiet and concern for my family. What we see is that anti-LGBTQ homicides doubled in 2017, and that number continues to rise. This picture reflects a protest. So these people are not actually dead, which I hope you can see from their gravestones, but reflects the trauma inflicted on the queer community by the AIDS epidemic. So this reflects the lack of ability to even obtain normal health care, to be able to go to the doctor, to have someone come into the room with us or touch us. And this, of course, and I don't need to tell you all this, but this specifically affected gay men. And it was queer women and other gay men that came forward to take care of the people who were afflicted by AIDS, because no one else would touch them. And when we look at our current populations, our current epidemics or pandemics, who is coming forward to take care of the oppressed populations? Who steps up to take care of those that society deems otherwise untouchable? And I hope that it is you all. I hope that it is me. I hope that it is the people that I love and trust, and that we come forward to take care of those that others won't. This one is one of the most disturbing statistics. This is from the Trevor Project, which conducted a national survey on LGBTQ youth mental health. This is from 2021. And what I will point you to is this very first bullet point: 42% of LGBTQ youth seriously considered suicide in the last year, and more than half of those were transgender or non-binary. Look then at the next bullet point, which increases that amount and that number based on additional minority groups. So Native or Indigenous groups, Black youth, multiracial youth, and Latinx youth, Asian and Pacific Islander youth as well. All of these racial minority groups, on top of being queer or being within the queer community, have such an incredibly high rate of either suicidal ideation or attempts. You can then see on the other side the good news, and that is that we can make a difference in these numbers. Transgender and non-binary youth who were able to change their name or their gender marker had significantly lower rates of attempting suicide, and people who had access to safe spaces, so spaces that affirmed their orientation, affirmed their gender identity, believed them when they told them who they were, reported lower rates of suicide. So these statistics, these news briefs, these little screenshots give a quick snapshot into the health outcomes that queer folk experience, that we fight against, and that we are trying to rise above as we try to educate the nation and educate society to let us live and let us be who we are. So what is trauma-informed care, and what does that have to do with the queer community? Let's talk about the definition of trauma-informed care and the differences from standard practice, or I should say current practice. So trauma-informed care is this little continuum. So it comes from a place of safety. Safety is the first and foremost important piece of this puzzle. So safety is the most important thing. And what that means, what that practically means, is that we, the providers, so I'm putting us all in the same provider, whether we're doctors or PAs or nurses or lactation consultants, whoever we are the people in power. We are the ones with the knowledge, the access, the medications, the stuff. We are the ones with the power. It is our job to prioritize the safety of the disempowered or oppressed group. And in this case, and in the context of this talk, that is the queer community or any oppressed or marginalized community. So safety is the first and most important piece of this, at the expense of our own power. That's what trauma-informed care really is. So trustworthiness and transparency comes from creating a place of safety. We then also involve peer support. So when we are talking about trauma-informed care, we are talking about us, me, a cis, straight passing white lady. I'm not the right one to be talking about the traumas of that the Black community experience, or the traumas of the Native folks, or I'm not the right one. It's not me. I can talk about trauma-informed care because I use that in every part of my practice, but I'm not the right one. We need to bring in peer support, people who are on that same journey in just different places on that continuum. We need peers to help support this process. Collaboration and mutuality means that we are not alone. We attempt and make efforts not to work in a silo. We want to work across the healthcare community. We want to work around the barriers so that we are providing, again, always going back to that first step, we are continuing to provide and strengthen the safety of our spaces. We then empower the voice and the choice of the disempowered person, not our voice, not the voice of the people who have the power. We are giving this power back. We are ceding the power back to the people who are historically oppressed by our medical society and community and by our society at large. And then always with the understanding of the cultural, historical, gender-specific issues that affect your particular patient or patient population. Let me pause for just a second. Do you all have any questions about this this little cartoon thing about trauma-informed care? I'll give you a second to unmute if you have a question.
Katie, I do. Yeah. So in some ways, this isn't new, right? I mean, as part of being a good physician, and it was taught to us less formally in the past, don't you think? Or do you think it was just omitted entirely from our education? I'm just thinking about watching my attendings that I admired and how they dealt with their patients. And I think all these elements were built into it as part of being a good physician.
Great. Tersh, I love that. And that tells me so much about who you are as a physician and as a person, the fact that you saw that in your mentors. And I think we can all identify that this should be innate. Like, I always want to think like, oh, I always create a safe space. I always want, to make sure that I'm working in a collaborative way. You're right that that these principles are not new. What is relatively new, and again, I am not pretending like I came up with trauma-informed care. This has been around for a little bit, although it has not been in this continuum, and it has not been used in this way to describe the care, especially of oppressed populations. This specifically lifts up populations that we know, we have studied this, that we know suffer at the hands of the medical system. So we know that Black moms die way more often than white moms, that Native moms die way more often than white moms. The way that we fix that is by doing, the things that we are doing. We are trying to look at our system holistically to understand what is it that we are doing so wrong. This is one of the ways that that we save lives. This is one of the ways that we lift up the communities that are oppressed. We listen to and empower their voices so that we can make the changes that will save their lives, that will change our practice. So you're totally right, Tersh, that these principles in and of themselves are not new. And good doctors, the ones with the good bedside manners, are the ones that have been doing this for a long time. The difference with trauma-informed care as a model is that we are going to create clinics based on this model. We start from scratch. We change the names of our clinics, or we change all the signage in our clinics so that it is a space that feels affirming and right to everybody when they come in. I hope that helps.
Sorry.
Please.
This is Chris.
Hi, Chris.
Hi. Hi, Trent. I am going to bring up the recent bills that have been passed, and because you already talked about the children and, their suicidal ideation and all that kind of stuff, right? And then we've got this new bill that restricts them even further. And then when you're thinking about trauma-informed care, how are we going to kind of not break the law, yet provide that safety, that support, and all those things to address this population?
What a good question. And thank you for being so thoughtful about that. That's a really important question to think about when you are trying to provide a space or provide care that is potentially life-saving for these people whose state is going to kill them. Like the state is trying to kill them with this oppression. So when you are creating your forms, when you are creating the emails that go out, and you may not be the only one in charge of this, and we'll get to the implementation piece in a minute, but when you are thinking about every moment of your patient's experience as they come into the parking lot, into the door, into the waiting room, into your office, what can you put on the walls or wear on your lanyard or whatever to validate that person's existence? How can you, in a small way, counteract what the state is doing with these legal efforts? How can you, as one single person, and recognizing that you by yourself, you cannot change the entire state. You cannot change the entire system that is oppressive. But what can we as individuals do to try to make this one space, this one encounter, especially within the medical community, safer and a place of respite, a place of lightness for your patient who is suffering? So some of those things you maybe already are doing. Wear your pronouns on your lanyard. Ask people's pronouns before you assume. Talk about sex and babies and all the things with gender neutral terms. Like when I talk to patients, I will, let's just say the patient is not currently pregnant, but they want to be pregnant. I will say, like, okay, are you currently having sex with someone with a penis? I don't actually care what their gender is, what pronouns the other person uses. I'm not really thinking about that. I just need to know if there is a penis involved, where we're getting the sperm. Like, that's all I care about in that moment. So taking away anything that doesn't have to be gendered really gives space for whatever is happening, whatever things. And it may feel awkward and weird at the beginning, but you may this is another key component of this trauma-informed care. Our feelings of awkwardness or tripping over language or feeling a little uncomfortable using some different verbiage is life-saving. So our awkwardness does not mean that we get to continue this oppression. So us feeling like, oh, but they is so weird to call somebody like, oh, it's hard to use they, them pronouns. That may be awkward for us. We may not like the grammar that comes with it. You may not like that. That person may not kill themselves because you use their right pronouns. Like that is the absolute fact. That is what the data suggests. So when we are thinking about what we can do, as you said, what are we going to do and not break the law? We can still use the language we want. We can, still wear stickers or things on our lanyards. And maybe your clinic doesn't like things on your lanyards. I'm a big old like bling fest when it comes to my lanyards. You can use signs on your walls, art from queer artists or things with rainbows. Like not everybody loves a rainbow and that is fine, but rainbows in a professional setting tell you that there is somebody here that is thinking about this. There is somebody here that wants it to be a safe space. It is the beginning of what we can do. It's the least that we can do. Any other questions at this point while we're stopped? Thank you, Chris and Tersh, for those questions. So when we're talking about trauma-informed care, we're going to not ask things like, what's wrong with you? Even in our brain, like you would never ask that of a patient, but don't ask it in your brain either. Not what's wrong with you. Ask what happened to you. What happened to you? What happened for you, with you, who was there for you, etc. Ask about the experiences. What of those experiences, whether childhood or adult, contributed to the current presentation? Is it a healthy relationship? What kind of coping mechanisms are people employing to get through a stressful time, etc. As we are moving toward what happened to you, how can I support those experiences? How can I be more knowledgeable and informed about those experiences? Then we blossom out toward the clinical and organizational implementation of trauma-informed care. This is where it gets tricky because it has so many stakeholders and so you need so much buy-in. But again, when you are in states like ours, where our states are legally oppressing people and are trying to use legal action as a means of oppression, it becomes even more our jobs and our responsibilities to create spaces that are safe, whether that is just in your little cubicle of an office, or whether that is within your entire clinic setting, or whether it's within a whole hospital setting. All of those efforts and movements make a difference, and they all make things better. So these are some of our guiding principles within trauma-informed care. All of these are on, there's a really, really great website that I'm gonna give you that has individual trauma-informed care principles, as well as some clinical and organizational implementation skills. But it always comes back to these things. So again, these are the same principles as we saw before, just in a slightly different diagram. Remember that it always comes back to safety. We want the decisions that people make to be made with transparency, and we want that goal always to be with trust and safety at its heart. Coming back down here to empowerment, remember that our strengths are within us and they are not within the organization. The organization is only as good as the people that work for it and work within it. That's us. This is where we can come in when it is a whole organizational implementation that we're talking about. We are the ones that will make the change because we are the ones that will lift up those populations, lift up the concerns. We will identify the things that are oppressive and are problematic, and we can help mitigate those. So we have a huge role to play in the implementation process. Again, this does not fix what's happening at our state houses. It does not fix what is happening even at the highest levels of our hospital settings. But if we can start with a small, safe space, it will grow. Other people will be inspired and moved by the work and the change that you are creating in your space, and your patients will see and feel the difference. They will see and feel the effort that you are putting in to create this safe space. So this implementation, so how does this work actually in practice? So this website that I want to send you to is this down here, traumainformedcare.chcs.org. It has all kinds of great things. We will talk pretty superficially about this because that my understanding was that this was not the point of this whole talk, but I did want to make sure that you had some kind of tips and tricks about what to do. So organizationally, make sure that after this training, or not even a training, after this session, you will have a little bit of training. You will have a little bit of understanding about what trauma-informed care is, and you can be a leader about how to be trauma-informed, how to get better trained in trauma-informed care, and then you can help create that shift in your practice and in your space. Oh, I forget your name. Trent, maybe the guy that's graduating. Super excited for you. Congratulations. You have the ability to create this in your new space and in your new practice. As you are developing who you want to see, what you want to do, what you want your practice to look like, make it look safe. The people around you feel safe in making others feel safe. Bring all of this with you. Remember to try to this number 5 here, prevent secondary traumatic stress in staff. This is huge. So one of my clinical subspecialties, I said earlier, I do abortion care, which is very traumatic in times like this. And the other thing that I do, my other job is that I do chronic pelvic pain. So I have my own small practice that I just treat chronic pelvic pain. And I have to do a lot of emotional regulation of myself and of the people that support me because of the stress that hearing people's traumas puts on us. The same goes with treating anyone who is marginalized. Any kind of trauma that you are listening to is potentially secondarily traumatic to you. So make sure that you and your staff are taking care of yourself. That is just as important to take care of yourself as it is to take care of the people in your office. The clinical practices over here specifically are reflective of how we interact with patients. So involving patients in the treatment process. This means that instead of saying, well, let's start you on some birth control, I think that that's probably going to do the best thing to control your periods. You say, what's been your experience with hormones or contraception in the past? Have you ever tried to control your periods with anything before? What do you think we should do? Many patients will say, well, I don't know, you're the doctor, but they get to say that. They get to be the ones to be like, well, what are your ideas? Okay, then I'll pick from those ideas, as opposed to us writing out a prescription and sort of tossing it to them and heading out and leaving the room. It is so impactful when we return that power back to our patients. Remember to screen for trauma. So when I was in residency, which is not like that long ago, but it wasn't like yesterday, we were starting to screen for some trauma, like sexual trauma or physical abuse. But even then, we had no infrastructure about like what to do if we found trauma. Like, what are we supposed to do if somebody says yes? What are we supposed to do about that? Well, now we know, based on so much research, that literally just asking about trauma, even if it is just on your intake forms and you never say the words, you will literally impact their health by just screening for asking about trauma. The acknowledgement of someone's trauma can be just as healing as going through a whole process to heal and intentionally change from the trauma. Just showing interest, showing that you understand and acknowledge the impact that trauma had on them can be incredibly impactful. Training your staff for trauma-specific events or treatments, and remember to engage in referral sources and partner organizations. You are not alone in treating people. You are not alone in screening for trauma and then not knowing what to do. So I've got a bunch of resources for you, but don't be afraid to reach out to other organizations or other people if you come across something you don't understand. And remember to tell your patient that this is really awful for you. I hate that you're going through this. I want to make sure that you get the best treatment, and I don't know if I'm the right person to do it. I'm going to ask some of my colleagues and I will get back to you. Or let me send a message right now. Maybe they'll get back to me while we're sitting here. Something like that. People love that. People love to feel prioritized and heard, and that you are going to act on their behalf. Just do that and people will love you for it. And that's of course not why we do it, but it's a nice bonus when they do like you. Remember that when you are a patient and you are walking into an office, so much of our interaction or our impression of that office is has nothing to do with the doctor, has nothing to do with the PA, has nothing to do with the healthcare staff at all. It so much has to do with the front desk person or the parking attendant or the fact that the garage was full or that you don't like anything in the vending machine. So remember that that same thing goes with trauma. So if you are someone who uses pronouns that don't necessarily look like what you would identify, or you have a name that does not align with the name on your driver's license or something like that, it is actively traumatizing to have that interaction, to have that experience. And so remember to train and lift up the experience with your non-clinical staff as well. They have a huge role in making sure that your patients feel safe, feel welcome. They should always be included in your trainings and in your awareness. This says awareness building events. So make sure that you bring those in as well. Make sure also that you are lifting up the literature. So there is so much literature about trauma-informed care, and then of course about all of the specific marginalized groups. So as I'll talk about in a moment, the OutCare Health Group has tons of literature that you can put out. You don't ever even have to ask if someone is queer or within the LGBTQ plus community. They may pick up the pamphlet and be like, oh, I love that you have this out here. This is me. This is what I identify as, or they may make a comment about it or whatever. That literature may make a huge difference to feeling accepted and seen and safe to be able to talk about it. As you are implementing these policies and strategies in your organization, make sure that you surround yourself with people who value the same trauma-informed approach, and that these people are willing to get a little bit uncomfortable, willing to get a little bit out of their standard zone, the treatment patterns that we're so accustomed to, and be open to adjusting some things so that they can see things a different way and treat people better. So these specific LGBTQ plus implementation of trauma-informed care, we've already talked about several of them. Pronouns, ask everyone, and everyone should wear them. You should ungender as much as you can. Bathrooms, handouts, clinic name, website information, all of your signage, etc. When you are screening, make sure you're screening for actual evidence-based risks, not just what you think they might be exposed to because of their practices, preferences, behaviors, identities, etc. So just because a male presenting person says that they have sex with another male presenting person, that does not necessarily put them at risk for different diseases than anyone else in the world, because these male presenting people may not have penises, they may not have anal sex, they may not have the kind of risky behavior that you would otherwise associate with contracting different diseases or having exposures. Similarly, just because someone is married does not mean that they're in a monogamous relationship. So don't assume that. So make sure that you are screening for actual risk and that you're not just screening based on your assumptions. Again, always, 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 as much as you can, intentionally and consciously return the power back to the patient. So I will always tell my patients, I will literally say the words, you are always in charge here. You can always tell me if you need me to stop, if you need me to leave, if you need to leave, if you need this whole thing to be over. My feelings are not what is important, and my feelings will not be hurt if you need me to stop. It does not matter. So please just let me know and I will stop. Same with the exam. So if you can't justify why you need to do your exam, if you're like, well, I mean, she should probably get a pelvic exam, it's been a while. If you can't justify a specific reason, you probably shouldn't do the exam. And if the patient has any kind of pushback, any kind of like, well, I'm not comfortable, I had a bad experience, whatever, spend your time talking about that, talking about the experience, then send her home and schedule her back after she's had some time to think about it, and rest in, and she can spend some time resting in that experience with you validating her concern, validating the experience that she had previously, it will make her much more likely to come back, be much more cooperative, and feel safe. And this is a working relationship that you might be able to really foster, as opposed to force an exam on someone who really maybe doesn't need it, or if they do need it, only kind of consents to it because you as the provider say that they have to. So remember that you're always, always, always putting that power back to the person who has been disempowered. And in all of that, remember to always ask permission. Ask permission to come in their room. This is especially true in the hospital, where this is literally their living space. You would never just walk into somebody's house after knocking once. Knock, wait to be asked in, and then go into their space. Same with touching them. Do not touch people unless they have given you permission to touch them. So when you are gonna move their drape, ask if it's okay if you move the drape first. It's super easy. Is it okay if I move your drape? And then wait for permission before you do it. Very, very simple. These easy, simple, quick things, but they take conscious change. They take intentional effort on your part to change these very innate, natural things, like, oh, I'm just doing a quick pelvic exam, just quickly here, move on down. I'm just going to help you. I'll scoot you down. You know, like, that is super invasive, super potentially so traumatic to be have someone else move you and kind of move things around and quickly. Take 1 extra second and ask permission first. So here is sort of the end. So I have a whole list of resources that's on the next slide. This slide is the top 5 takeaway points. So remember that trauma has real and measurable health effects, and it is worthy of screening for. It is worthy of screening for. Remember that in addition to the normal traumas that we are learning about, how children are affected and their long-term health outcomes are different based on their different traumas and combinations of traumas, oppressed populations have even more trauma and suffer more as a result. Members of the queer community have statistically more assault, hate crimes, and suicidality. And then on the flip side of that, we receive less support, less resources, fewer resources, and less research funding to support us. Trauma-informed care is a method of providing care that empowers the traumatized person or group and prioritizes their safety over the convenience of the person in power. So remember that your convenience, our convenience as the people in power, is not as important as the safety of the person who has been traumatized. Our convenience is not as important as the safety of the person who has been traumatized. And these queer specific implementation tips or advice include that unlearning some of your bias and retraining yourself, making sure that you train your staff, especially your non-clinical staff, make your processes more inclusive, and remember to approach the entire appointment from start to finish from an informed and thoughtful perspective to the patient. Again, not our convenience, to the patient. So what is going to be best for the patient? Here are a bunch of resources. So remember that trauma is something to be screened for, and it can cause all of these other long-term downstream health effects. So substance abuse, mental health services, this is an incredible guide for trauma-informed approach. The ACEs Aware website is a place where you can learn more about the ACEs study and all of the studies that have come from that. That trauma-informed care implementation resource center that I mentioned earlier, that's linked here. The Trevor Project and the Human Rights Campaign is linked here. Born Perfect is a campaign, a national campaign to ban conversion therapy. No matter what, recovery is a specific trauma recovery place or organization that has a special place for the queer community. And then Outcare Health is an organization that I highly recommend that you all look into and join as a provider who is trained, who is capable, and who is willing and excited to take care of the queer community. We, the queer community, need more people to come out and be proud to take care of us and to be on our side. Here are some of the major landmark references and and I will send plenty more if you are interested or want them. So this is my little family, and including one of my dogs. We are grateful for you. We are grateful that you showed up today and that you continue to show up for your patients. The people in this country and in this world need more people like you. We need people to stand up and be willing to take care of us, learn more about us, learn about our specific experiences and how they are different than a straight person's experience, and how we need a little bit different care or treatment. So we're excited to have you on board and in the ranks of the people who will care for us. That's it.
Thank you, Katie.
Yeah, I'm happy to send my presentation so that you all have all those links and resources and everything. So I will happily do that because I have all the links embedded. So it'll be easy for you to click on stuff. But I'm excited to share that with you.
We'll get that, and that'll be on the Montana Moms website. And I just, this is the second time I've heard you talk on this subject, and every time I've learned so much, Katie. It's amazing. And I think for all of us, but young doctors, young providers, I mean, this is what's going to make you a good provider. It's not how well you can tie a knot or do all that. It's how you can make people feel comfortable and address their needs. I mean, this is wonderful.
Thank you so much. I'm so glad. I so much agree, because tying knots is a skill that we practice and we learn. And this is no different. Practicing, like asking permission before you touch someone, it's just a skill. It's just a skill that you just have to remember, like, okay, first, when you're tying a knot, you go this one over this one, and then you push down with your index finger. Okay. And then when I'm doing a pelvic exam, I ask permission before I touch. Okay. All right. Yeah. I mean, it's literally just a skill.
Can I ask, if we have time, Tersh, I have a question.
Yeah, go ahead.
I wanted to chat about the pronoun situation. So I advocated in my clinic to get pronoun tags for everybody. And one of our diversity inclusion officers suggested not requiring it to be worn by everybody because he was concerned about forcing people to out themselves. And I know you said we want to ask everybody too. I wanted to hear your thoughts on that, because I'd never even thought about that. I was thinking from the perspective of, there are going to be people who don't want to do this because they're not allies or they're not supportive. So we should expect them to. And he came from the other opposite of, we need to keep people safe.
I love that. Thank you so much for that. That is such a thoughtful and insightful perspective. And I love that resonated with you. I've had some experience with that in my clinical spaces. And what I recommended is, if people don't want to, I mean, I don't care if they want to or don't want to say their pronouns, but I would love if they would put a little rainbow sticker, or if they would say, like, this is a safe space, or something along the lines of, like, I am still a safe space, even if I don't necessarily want to disclose my own identity. That is fine. So when you're sort of looking at that broad implementation, that is a great perspective, is to have individual discussions, let the person themselves, the staff or clinical member themselves, have a discussion or an interaction with the patient. But I would advocate for there being some physical presence of safety. It doesn't have to be a disclosure of their own identity or past or secrets or whatever. Like, far be it from me to try to out somebody. But I would love for there to be some way that that we display safety. What other questions do y'all have?
Anyone else? Margie or Sam or?
And Jessica, I see that you're saying it's probably important to not assume that someone without a sticker or a badge is going to provide bad care. Like, absolutely, yes. Yeah, stickers do not make a good doctor or a good nurse or a good anybody. That's absolutely true. And that goes back to Tersh's point of that this kind of effort is what differentiates a good doctor from a great doctor, is the ability to do a surgery. Like, we can teach that to a robot. We can teach that to we
Oops, Katie, you froze.
That they're not a good doctor or a good person. And just because they are wearing a sticker doesn't mean that they're a good doctor or a good person. Like, absolutely, yes. So stickers and badges and so forth are one little piece of a puzzle of how to create spaces that are safe, spaces that are inclusive, spaces that are validating for the human beings that trust us with their health and their histories and their past.
Great. Katie, thank you so much. This has been so wonderful. You know, I want to just send out your presentation to every doctor in my clinic, you know, because I think this is where we need to go. I mean, it's fantastic. So thank you so much. We don't have time for a case today, and that's all right. Just thanks for joining us. Hopefully I'll get to see you next, you know, at the ACSM or
I would love it. I hope I get to at least cross paths with you and give you a quick hug. Thank you everyone so much for joining, and thank you again for your effort and your interest.
take care.
Bye.